Mara Youdelman is the managing attorney at the National Health Law Program, and Mara was one of the founding commissioners for the Certification Commission for Healthcare Interpreters, and as chair of the founding board of directors, really ended up serving as a staff person for many, many years. And I think what is not known about Mara is that Mara is also really a bridge builder, that in her position, even though she was working for a legal organization, which is probably the type of organization that many of the other stakeholders would have run from, she was able to forge relationships with hospital associations, with physician organizations, to bring organizations like the American Medical Association, which really actually opposed language access as a formal position, to say that it wasn't the responsibility of doctors to take care of patients in their own language and communicate with them in their own language, and that was somebody else's responsibility or the patient's responsibility. And so Mara really built those relationships very, very patiently, very, very strategically, and really helped, I think, build this field of language access, of whom healthcare interpreters are obviously the core and really important, but you need all those other stakeholders with you to support your work, to support your profession. And so it's really my pleasure to introduce Mara for one of our keynote speakers.
Thank you, Ignatius. And I was going to say, it really is due to Ignatius's work at the California Endowment that I get to stand with you today, because in large part his funding of the National Health Law Program and many of the other projects that Margarita mentioned let us become knowledgeable about these issues, working on these issues from a variety of perspectives. So no, I am not an interpreter. I am a lawyer, so don't hold that against me. I also do live and work inside the Beltway in DC. But I really am honored to be here, and I really do thank Ignatius and his work at the California Endowment for having the foresight to realize that we needed to look at the big picture, as well as focus on the healthcare interpreting certification. And so a lot of the work that I've been very privileged to do with the National Health Law Program to advance the field is due to Ignatius's foresight and willingness to sort of provide some funding that helped my organization have its commitment and continues to this day. So I have been asked to talk about the state of play. So as much as I would love to just sit up here and talk about CCHI's history and celebrate, and we are going to be celebrating the rest of the day, I am going to provide a little bit of the reality check, and so it's kind of hard at the beginning to be a little bit of the downer, but hopefully we're going to end on an up note. That's my goal. But what I really want to talk about is some of the challenges that are facing the patients and clients for whom many of you are interpreting on a daily basis or working on behalf of, because this is very challenging times. And I think while we are certainly celebrating the birthday and the anniversary of CCHI, it is within a broader context of a lot of attacks on the very people for whom interpreters are working on a daily basis. And so part of what I'd like to do is bring a little bit of that lens and also just information to you that hopefully will help you engage and share with your patients, and then also what you can do going forward. So let me just check that my little thing works. All righty. So, and usually I start off by saying, well, you know I'm a lawyer, so that's one strike against me. I live and work inside the Beltway in DC, which these days is definitely another strike against me. And I also talk fast, but I'm going to try really hard, and I've let the sign language interpreters to please like raise their hand or wave at me if I'm talking too fast, but I know they're great and they're going to be able to keep up, but I am going to try to talk a little bit slower than I normally do. And also a huge welcome to all of you who are with us virtually. Believe me, I'd love to be in my pajamas doing this, but decided I would actually, put on a blazer and clothes today. So if you're not familiar with the National Health Law Program, we're also called NHELP. We are a national nonprofit law firm. We have offices in DC, in Los Angeles, and also in North Carolina. And we work on behalf of low-income and underserved populations. Our work on language access predates me. So I've been at NHELP since 2000, but we have been working on language access issues since way before that. And if you take a look on our website, we actually have a lot of resources that are available to help you all make the case as to why language services is necessary. part of what Ignatius helped us do is sort of gather the research base and the literature to show why language services is so important across the country and not sort of just in pockets where people may think, oh, this is a high immigrant population area, so we need to have interpreters. I'm going to start with the invisible wall, and I give credit to the National Immigration Law Center and Protecting Immigrant Families, which is a nationwide campaign I'll talk a little bit about. But we really are in challenging times. The attacks on immigrants, and I'll be clear, not everyone who is LEP, as we know, is an immigrant, and not everyone who is an immigrant is LEP, but that Venn diagram is pretty much of an overlap. And so a lot of immigrants in this country right now are facing huge challenges because of what this administration is doing. And it starts with the Muslim ban that we saw very early on in the administration. It goes through the family separation policies and the trauma that has created. It goes through the building of the wall to keep people out of this country. And then it goes through a lot of issues about public charge, which I'll be talking about more in depth, census questions, restricting benefits, we can go on and on. But I think as sort of the overarching, we need to realize, and I'm sure you have all seen this, is that there is a huge increase in the fear that individuals have in general, and then certainly also in accessing healthcare. And so knowing what's behind some of those policies, I think is really important so that you can help explain what the real repercussions are, but also the perceived ones that maybe you can help people understand and potentially overcome so they feel more comfortable accessing healthcare services. So here's what I'm going to talk about today. I'm going to talk about public charge, and I'll explain what public charge is. How many of you have heard of public charge? Let me just, okay, great. I'm going to talk about the Affordable Care Act's non-discrimination provision, also known as Section 1557. How many of you know about 1557? Okay, great, a little bit less than that. And then I am going to try to end on an up note, I promise. So looking beyond what's going to be happening in 2020. So let's start with public charge. And I know you're not supposed to do this in a presentation, but I'm going to start with the punchline, which is the good news. And I had to change my PowerPoint yesterday because all of this happened late yesterday afternoon. But 3 different courts yesterday issued injunctions, that's a technical legal term, but prohibiting the administration's terrible, horrible, no good, very bad public charge rule. I got to try to keep you entertained, I realize that, it's early, from going into effect. So despite everything I'm going to tell you about, because it is important to understand what the rule does, it's not going into effect now. And that's important to know in large part also because people don't understand that. And people think it's already gone into effect and they're worried about the implications and they're making decisions that now, at least at the current time, they shouldn't have to be making. So we have 3 different federal courts that put this prohibition in place through what's called either a nationwide injunction or an injunction. Now, there's a lot of steps ahead. So we won yesterday, we're celebrating that, but it's a long process. But what the short version right now is the public charge rule is not going into effect on October 15th like it was supposed to. And therefore we can celebrate that and wait for these court cases to play out, and it will take months, if not years, for that to happen. So what is public charge? It's one of those terms that you say and people are like, huh? It doesn't have any relationship really to what it actually means in practice. It's an immigration term. It's been in immigration law since the late 1880s. And it basically, the immigration law says if you are deemed likely to become a public charge, you might not be able to get a visa to enter the United States if you're out of the United States. Or if you're in the United States, we're not going to let you get your green card. And so it applies in these 3 situations. It does not apply when someone's applying for citizenship. That's also really important. So anyone who has their green card and is applying for citizenship, there is no public charge determination at this point, okay? So long-standing, and this is actually one of the first issues I worked on when I moved to Washington, D.C. in 1998, before I was at the National Health Law Program. It was very soon after Congress passed what we call welfare reform, which restricted many immigrants from accessing most public benefits for the first 5 years they were in the country, federal benefits for the first 5 years they were in the country. And there was a lot of fear at the time of what does this mean? If I'm eligible, can I get these benefits? If I'm not, what should I do? And so a number of us worked really hard to get some policies put in place by the then Clinton administration to define what public charge meant. And what they said is it's only going to be looking at two types of benefits. So if you get cash benefits like welfare payments, you can call it temporary assistance to needy families. It used to be AFDC, or if your state has something like a general assistance program, if you're getting cash from the government to help you live, that would be considered in public charge. And the second would be long-term institutionalization at government expense. Most of that was happening through Medicaid, which will pay for nursing home coverage. Not regular Medicaid, but just the institutionalization. Sometimes there also would be state-funded programs. So from the late 1990s, actually 1999, and now given these injunctions through today, those are the only two things that can be considered in terms of public charge. So the other thing is that it's also forward-looking. You're not supposed to look back and say, oh my gosh, you got cash assistance 5 years ago. Now you're going to be a public charge going forward. We're supposed to look forward. So public charge takes those binoculars, looks ahead and says, in the future, are you likely to be a public charge? And they're supposed to consider, according to the law, these circumstances like age, health, family status, etc. Okay. Another important thing, and this is part of the confusion, but public charge does not apply to everyone. And again, this is important. There's lots of people who are excluded. So asylees and refugees and survivors of domestic violence and certain other individuals are not subject to public charge. But I've probably already confused some of the people in this room or virtually. It's very complicated. And so in the communities that are hearing about this, they're like, oh my gosh, we've heard that there's changes to public charge. We're just not going to access anything, even if it doesn't even apply to them. And that's where we get into the problems that we'll talk about a little bit later. So this administration put out a proposed rule that wanted to dramatically change the definition of public charge. This rule comes from DHS, which is the Department of Homeland Security. There was a proposed rule, there was a public comment period, 266,000 individuals and organizations submitted comments. The vast majority opposed this rule, but the administration still went ahead and made changes. And so what they did was they put in a new definition of public charge. They put in some new factors saying we're going to negatively weight certain factors if you've accessed public benefits. And then they went way beyond the definition of cash assistance or long-term institutionalization in what they were going to look at. So in this final rule, these first two sort of light green boxes is what's always since the late 1990s, been considered in a public charge evaluation. And these other three boxes, the dark blue, looks at what was added. And so it was going to add receipt of Medicaid, receipt of food stamps or a supplement or SNAP, and receipt of housing assistance. So this would vastly broaden it. And it goes way beyond sort of government subsistence. There are lots of people in the United States who might get food stamps, but have a job, be primarily self-sufficient. So they also, as I said, they also sort of expanded the rule, and they were going to say, if you've received benefits in 12 months of the last 36, that's also going to be considered as public charge. And if you receive two benefits in 1 month, so if you're on both Medicaid and SNAP, that's going to count as 2 months. So it's going to make it even quicker that you would be considered a public charge. So again, these were sort of the provisions that this administration wanted to put into effect to dramatically restrict both who was going to start accessing benefits and then who would be able to get their green card or even be able to enter the country. The final rule also put in definitions of these factors that were in the statute, but it said, okay, well, working age is 18 to 62. So if you're older than 62, well, we're not going to assume you can maybe have a job, and we might look at that negatively. If you're diagnosed with a medical condition that could affect your ability to work or study, and you don't have enough resources or money or private insurance to show that you can pay the cost of that medical condition, we're going to look at that negatively. We're going to look at your household size. The larger your household size, the more resources and income you're going to need to show us you're not going to be a public charge, and on and on. So again, it really, I know I'm downing everyone, I'm sorry. I promise it will get better. So there were a number of these factors, and the federal rule is very complicated, but they did exclude certain benefits, and so this was a positive thing. So things like the Children's Health Insurance Program, which may be called different things in your state, There's Dr. Dinosaur, there's, I forget what some of the others are. Women, Infant, and Children's Program was excluded, Medicare was excluded. If you were getting Obamacare or Affordable Care Act coverage on the marketplaces or through healthcare.gov, that would be excluded. And any benefit not listed in the regulation would be considered. There also were additional exceptions. And again, this gets into the technical pieces, but some people receiving Medicaid, it would not count for public charge. So children, pregnant women, school-based Medicaid services, and then if you received services while you were not a public charge. So it's really complicated, right? How do you know if you're in, you're out? It's going to be considered, when it's going to be considered, if you're an exempt category. You just hear public charge, and the chilling effect that happened from the very time that this issue was even leaked, rumors that there was going to be changes to the rule. We saw a huge impact on the affected communities. And we call it the chilling effect. Because if you actually look at who is subject to a public charge determination, you know, it's a good number of people, but it's about, you know, like, let's take this. And so there's a circle of people here. The number of people who thought they were affected goes out to here, because they just don't understand what we're talking about. And then if you add on the families and a lot of times the citizen children of individuals, we go out to here as well. So it really was sort of, you know, you can say a very cunning move on the administration's part to make these changes, because they realize that it's just really hard to understand the permutations and the possibilities. And people are going to act and say, I can't even take benefits because I'm so worried it's going to affect me, my family, or if I want to sponsor someone coming to the country later. There's huge confusion. It's very complex. Plus the individuals who make these decisions, whether it's consular offices overseas, if someone's trying to enter the United States, or agency staff at the Department of Homeland Security here for people applying for their green cards, they have discretion. So it's not sort of a hard and fast decision, because again, you're looking forward. So, okay, we're going to look back to see what you've done, and we're going to project forward to say, are you likely to be a public charge in the future? What we saw after 1996, and why we worked really hard to get clarifications then, is we saw a 25% decrease in the use of Medicaid by children. That's huge. And it affects all of us because of public health implications, because of the ability of those children to grow up healthy, to learn in school, et cetera, et cetera. If you look at some of the other statistics, we have about 26 million people who might be chilled from participating. And 1 in 4 children have an immigrant parent. So this includes citizen kids who are completely eligible for these benefits, whose parent may now be concerned about public charge and say, I'm going to forego all benefits, not just for me, but also for my citizen kids, because I don't want to take the chance that I'm not be able to get my green card or be able to come into the country. So in effect, this hurts all of us. I mean, we sort of all know the implications of public health. We're all worse off when people don't have access to whether it's healthcare, nutrition, or housing supports. And the rule is grounded in the false claim that receiving benefits means you're not contributing. That's not true. People may get a sort of a helping hand. We all know healthcare is incredibly expensive in this country. If you're not getting it through your employer, buying it yourself is ridiculous. And particularly if you're eligible for Medicaid, because I'm tight, that, you know, you really want to make sure that people have access to the healthcare they need. It helps all of us. And so unfortunately, many individuals may go uninsured because of their fears. So yesterday was a really good day. Let's get back to the positive. I'm going to go through, there were 3 different court orders, but the order that came, or the decision that came from California, probably went most in depth as to why the administration's actions are likely to be found illegal in the end. So what happens when you get a preliminary injunction? It's the very first step, you know, that plaintiffs in a case can ask for, the ones who bring the case. The cases were mostly brought by states and by counties, as well as by some nonprofit organizations. And they basically said, if you let this rule go into effect, there's going to be irreparable harm across the country, both to the individuals who will forego their benefits, but for the states and counties, lost money that they would get because people would drop out of Medicaid or other programs. So the court has to decide that you are more than likely to sort of prevail in the ongoing litigation to even grant a preliminary injunction So it is good news that we got these. And basically what the court decided in California is the rules definition contradicts longstanding interpretations. And they spend pages and pages of this decision going through the whole history of public charge back to the 1880s and explaining why what this administration did is so far beyond what Congress ever intended when it discussed public charge and what the courts have ever looked at when they've been interpreting public charge. So as one example, they said if you are a higher income SNAP recipient, food stamp recipient, you may be only getting 50 cents a day in food stamp benefits. There's no one that can say that that's subsistence from the government. And yet the new rule, if it went into effect, would allow that to be determined to public charge and possibly deny you a green card. Okay, so that's the kind of evaluation that the court made in California, which I think is really strong. It also said, and again, this is a legal term, but that the Department of Homeland Security acted arbitrarily and capriciously. When an agency is trying to change a longstanding policy, it has to give reasons why it's doing it. And those reasons have to be based on either new facts or evidence or, a reason to make the change. Also, there's a public comment period. And so when I said 266,000 individuals or organizations submitted comments, that was huge. And the vast majority, 95%, at least 95% were saying, don't make these changes. And then giving lots of evidence as to why, not just saying we don't like it, but saying this is going to be the impact on our communities, this is the impact on our hospitals, this is the impact on our states. And the administration pretty much ignored that and didn't consider the harm that it was going to cause. That's why the courts were also able to say, at least preliminary for now, and issue these injunctions. So what's next with regards to public charge? The legal challenges are going to proceed. We are expecting the Department of State to, it actually just did. The Department of State just issued what's called an interim final rule. They were trying to change their policies to match what the Department of Homeland Security did. And this is more for individuals who are overseas and applying for a visa to come into the United States. And then we also expect the Department of Justice is going to issue a rule very similar to Department of Homeland Security, applying to deportability based on public charge. Now, again, based on what we've seen for the DHS rule, which applies to admissibility or getting a green card, it's very likely these other changes will be challenged. They can't be challenged immediately. We have to wait for things to be finalized. But I think we're in very good position right now. So again, what you need to be thinking about doing is helping your patients and clients understand this very complex issue, but mostly understanding these new rules have not gone into effect. They're on hold. There's no reason that they can't be accessing benefits and using the services to which they are entitled. Well, I didn't include it, but actually if you want more information, there's a lot of really good materials at the Protecting Immigrant Families campaign. It's protectingimmigrantfamilies.org. There's consumer-facing materials or materials available in other languages that you can help share the word and help educate yourselves and educate other individuals about what's going on. Okay, so next topic. Yes.
Could you repeat that?
Yes, protectingimmigrantfamilies.org. I may have it later, or I may have deleted that slide, but protectingimmigrantfamilies.org. It's a nationwide campaign that is led by the National Immigration Law Center and the Center for Law and Social Policy. Full disclosure, we are on the steering committee at the National Health Law Program, but there's a lot of great materials. And as an organization, you can also join the campaign and decide to get involved as well if you'd like. Okay, so now I'm going to switch and talk a little bit more specifically about language access. And so the Affordable Care Act included a new non-discrimination provision called Section 1557. Some people also call it the Healthcare Rights Law. So these are my legal slides, and I apologize, it's early in the morning, but we'll do it quickly, we'll do it together. Let's go back to Title VI. Title VI of the Civil Rights Act of 1964 basically says if you take federal funds, you can't discriminate on the basis of race, color, national origin. Okay, it doesn't say language access in the statute, but there's a Supreme Court case as well as long-standing policy from Department of Health and Human Services that says language can be a proxy for national origin. So the real short version, Title VI, which you're probably all pretty familiar with, is if you take federal funds, you can't discriminate on the basis of language. And so when we came to the Affordable Care Act, enacted back in 2010, a number of us in DC wanted to include a non-discrimination provision in the Affordable Care Act. Some of it is similar to Title VI, some of it goes beyond Title VI. It's also important that you understand that Section 1557 is not just about race, color, national origin like Title VI was. It goes way beyond that. So for the first time, Section 1557 prohibits discrimination on the basis of sex, gender identity, and sex stereotyping, as well as reinforcing Title VI. So if we look at the differences between Title VI and Section 1557, both of those statutes apply to anyone receiving federal funds. So hospitals, Medicaid agencies, nursing homes, refugee resettlement agencies, et cetera, et cetera. Anyone taking federal funds can't discriminate on the basis of language. Section 1557, as I said, goes a step beyond that. So it also says it applies directly to federally administered programs and activities. So Medicare, you think of as a federal program, right? And Medicare providers, most of them, were subject to Title VI. But HHS's operations in administering Medicare weren't subject to Title VI. So for the first time, 1557 says if you're a federally administered program or activity, you now also have to comply with Section 1557. And then it also applies to state marketplaces and the qualified health plans that participate in those marketplaces. So it goes beyond Title VI and also gets us into a lot of private insurance. So, okay, you are going to get a little legal lesson, bear with me. But this is important to note because we've gotten a lot of questions about this. I call it the hierarchy of laws. A statute is the law that's actually passed by Congress, signed by the president, and you can't change it until you go through that process again. So if you have a law in the books, like Title VI, like Section 1557, it's in effect until Congress decides to change that statute and the president decides to sign a new law. Regulations are a step below that. Usually if you look at a statute, it can be very broad. If you look at Section 1557, it's literally 2 paragraphs. And it says you can't discriminate on these bases. It doesn't provide a lot of how or implementation. So a lot of times the agencies, whether it's Department of Health and Human Services or DHS like we saw for public charge or other federal agencies, are going to take that statute and say, okay, we're going to put some meat on the bones. And we're going to explain what this means. And regulations is a process by which you see that. So they will issue a proposed rule, they'll take public comment, they'll finalize a rule, and they can't change regulations until they go through another public comment period. So like I just discussed with public charge, what we saw, excuse me, what we saw, am I running out of time? Okay, just want to make sure. Just checking. So you have to change it. Guidance is a step below regulations. This can be a policy letter. The LEP guidance that we all talk about from 2003 that was issued by the Office for Civil Rights is just that, it's a guidance. It doesn't have the same force of law as regulations, and agencies it's much easier to include, to change those. So if we look at what we're talking about in 1557, Title VI, Section 1557 are statutory provisions. Can't be changed unless Congress goes back in and makes those changes. Regulations, we have Title VI regulations. We also have currently Section 1557 regulations that were finalized in 2016. And then under guidance, we have a lot of stuff on LEP.gov, and we have the HHS LEP guidance. So if we look at the history of Section 1557, it was enacted in 2010. First, the Office for Civil Rights put out what we call a request for information. They said, we want to know what the public is thinking. We're going to give you 7 questions. Give us your answers to these 7 questions. It's going to help us formulate the regulations, which will then govern the implementation of 1557. After that request for information, they put out a notice of proposed rulemaking. They took public comment. They put out final regulations. This was done under the Obama administration. And then now the Trump administration put out a new notice of proposed rulemaking. So that was put out in May of 2019, attempting to change a lot of the requirements that were in the regulations to date. So I'm going to walk through what the changes are for language access in detail, But as I said, Section 1557 protects more than language access. And one of the main reasons we wanted 1557 and helped get it into the law was recognizing the intersectionality of discrimination. That a lot of times you are not just discriminated because of your language, but you may also be facing discrimination because of your sex, or your gender identity, or your disability. And it's really hard to separate those out. So before 1557, we had one law that protected you from discrimination on race, color, national origin, another law that protected you from disability discrimination, another law from age discrimination, and then sex discrimination actually wasn't prohibited in healthcare. And so people found themselves in different legal bases, and it was really hard to get the same results sometimes if you were facing discrimination on disability and language access. You may have different rights and different remedies because you were falling under two different laws. So one of the main reasons for Section 57 was bring this all together and say it doesn't matter if the discrimination is based on disability or language or sex, you get the same rights, you get the same remedies, you get to go to court. And this administration is trying to roll that back. So they're really doing a lot of changes about trying to get rid of protections from discrimination on gender identity, sex stereotypes, and termination of pregnancy. But let's go through the language access changes. And again, these have not yet been finalized. And even when they are finalized, they will probably be subject to court challenge, but this is what this administration has been trying to do. The first is a 4-factor test. How many of you are familiar with the 4-factor test from the 2003 guidance? Okay, the 4-factor test has been around for a long time. And it basically is a balancing act. It says one size doesn't fit all. If the Office for Civil Rights comes in and says there's been a complaint of discrimination, we're going to look at a variety of factors. And back in 2003, when the OCR guidance first came out, we thought it was a pretty good test. The reality is the implementation of the test has been challenging because some entities will say, oh, well, I'm going to balance these 4 factors, and the cost to me of providing language services are so high, it defeats all these other factors, and so I'm not going to provide language services. And that wasn't the intent of the 4-factor test, but that's how it's been playing out. And so the fact that this administration is trying to put the 4 factors into the law is, again, one of the problems that we see because it doesn't put the focus on the individual who needs communication, it puts it more on the entity. So what we saw in these changes, and again, they were proposed, is in 2016, when the Obama administration put out the final rules governing 1557, which again are still in effect right now, they moved away from that 4-factor test and instead said you have to look at the individual. What does that individual need and what meaningful steps should an entity take to provide access? And what this administration is doing is, again, rolling back and saying we're not going to look at the individual, we're looking at the entity. And that's a very different focus. So we move away from patient-centered or client-centered and back into, well, the entity is going to consider a variety of factors. It does say language services must be free, must be accurate, and protect the privacy and independence. So those are good things. The 2016 regulation also included a definition of interpreter and translator. And this was actually a pretty good definition, adhering to ethics, demonstrating proficiency, including specialized vocabulary, terminology, and phraseology. And the 2019 proposal deletes qualified as part of the definition. Okay, now, yes. Yeah, exactly. So if we go back to what Margarita said when she began her introduction, having those little letters on your lapel is really important to show that you are an equal in a healthcare team, and you have those letters just like anyone else is going to have letters. The reality is they didn't change the definition. So it's the same definition, but just by taking out that word qualified, it doesn't seem that. And again, it's just one of those pieces that this administration has done and sort of just trying to show how it, where it is. But again, it's very concerning. There is at least a recognition, as I say at the bottom here, that not all interpreters can translate and not all translators can interpret. That's important. We've been working on that one, I think many of us in this room, for decades. It's implicit, it doesn't actually say that, but I think it is important just by how they define interpreter and translator. The regulation still does prohibit the use of minors and family members, so that stays the same. There were not changes in that. you know, we do, I'll just leave it at that. There was also changes in the provision related to remote interpreting services. So under the 2016 final regulations, if an entity was going to use video interpreting, it said it had to, you know, have video interpreting, a sharply delineated image. This administration went back and said you don't have to have good video interpreting if you have good audio interpreting. Well, this actually was for foreign language interpreting, not sign language. They did keep the requirements for sign language interpreting, saying that you do have to have the sharply delineated image. But, you know, again, it just shows like there's a lot of circumstances where remote video interpreting with a foreign language interpreter can be more effective. And so this administration, again, just made changes. They're subtle, but everyone in this room understands what that difference is. You still have to have a clear transmission of voices and adequate training. Okay, now we're getting into the meat of the changes. Taglines. Does everyone know, how many people know what taglines are? Okay, not everyone, good. Well, not good, but I mean, now you'll know. Sorry, now you'll know what a tagline is. A tagline is a really short statement. It'll say something like on a written notice, important. This notice is important. If you can't understand it, please call 1-800-XXXXXXX and ask for help. It's a visual cue in another language to help individuals who are getting a notice only in English understand that they can call and get help, okay? So it's not the best way. Obviously, ideally, you'd get someone a translated notice if they need it, but we all recognize we have a long way to go till that happens. Data collection is problematic. We don't always know what individuals need non-English notices. So sort of to come up with a compromise, in 2016, the Office for Civil Rights said, well, you have to include taglines on significant documents. So if you're getting a notice from your health insurer about your benefits, about your services, you're getting a bill, it was supposed to include taglines in 15 languages. So it's usually slapped on at the end. Many of you have probably seen them. And it was an important way to at least give some notice to individuals that they could get language services and how to get them. This administration has gotten rid of the tagline requirement. Gone. Completely. In large part, we sort of had a census was coming because some insurers, and particularly pharmacy benefit managers, were saying that this was too broad, it was too costly. The administration estimates it saves $3.1 billion. But again, this is a place where the administration didn't consider alternatives. So it could have limited the number of documents that these had to be sent with. It could have limited the number of times per year you had to send taglines, but instead it just said, sorry, no, gone, okay? The other piece that it got rid of was notices. So one of the other issues is not everyone in this room knew about Section 1557. And you all are a pretty well-informed group because you're keeping up on what's going on in healthcare. Think about all the LEP individuals across this country who have no idea that they actually are protected from discrimination. And so it's near impossible to reach out to all of them. So a requirement under the regulations was that entities had to post a notice. So I don't know if Alina has it, probably somewhere, you know, in the emergency room or in other facilities, post it in conspicuous places, include it when significant documents are being sent. And the notice was supposed to include basically 7 factors. The entity doesn't discriminate. It will provide auxiliary aids and services for people with disabilities and how to request them. It will provide language services and how to request them. There's a designated person who you can go to and complain if you didn't get services or if you need help, and how to file a complaint with the Office for Civil Rights. And basic civil rights information. Again, the proposal is to completely get rid of that. So we now have no notices and no taglines. So most LEP individuals under this administration's proposal would only get notices in English. And they may not know what they mean. And they may not know which is an important document and which is one that might just be informing them about some little extras they could get under health insurance. So where are we? The public comment period on this proposal ended in mid-August. HHS is now considering these comments. We expect that they will publish a new final rule with many of these changes. Once they publish it in the Federal Register, it usually takes effect 60 days after. And then we'll see if there's legal challenges. So similar to how we had to wait for the public charge rule to be published as final until we challenged it, we can't challenge these changes now. We have to wait until the administration finalizes the rule. So the other piece that I just want to raise quickly is because I've gotten a number of questions about that. If any of you use LEP.gov, which is a good clearinghouse for finding guidances issued by agencies, model plans, other resources, sometime last spring, there was this new little pop-up text. And as soon as you went to LEP.gov, you saw this text come up before you could get to LEP.gov that said basically these guidance documents are not intended to be final agency. They don't have legal binding effect. They have no force or effect of law. Yikes! What does that mean? Well, let's go back to our hierarchy of laws. When we're talking about guidance, these can be changed by the agency. They don't have to go through a notice and comment period in these formal processes. So basically, this is just putting everyone on notice that if you're looking at a guidance on LEP.gov or elsewhere on HHS or other agencies' websites, that the agency can decide to change them. So what's the impact of this pop-up text? It really is the optics. It's not like we didn't know that guidance wasn't binding, but they're explicitly saying it, and they're putting, everyone on notice that this could change. Further, enforcement has always ebbed and flowed. Individuals can file complaints of discrimination with the Office for Civil Rights. The Office for Civil Rights is supposed to investigate them, but depending on the president, depending on the priorities of the Office for Civil Rights, sometimes they do, sometimes they don't, sometimes they take years and years. But I think this pop-up text also sort of shows you where this administration thinks it's going in terms of enforcement. I also get a lot of questions whether President Clinton's executive order on language access could be rescinded. It could be. We haven't seen it yet. The reality is because they've done these changes in guidance, you don't really need to do much with the executive order, but we know that there are organizations who are pushing to have that executive order rescinded. Again, you can't get rid of the law. So the fact that the executive order may say some of the same things 1557 did, now that we have 1557, that executive order isn't as critical, but again, it's a political view. So if they rescind it, it's just one more piece of that, the impact on what they're trying to do with regards to rolling back language access. Yes, as far as, yes, because it gets published in the Federal Register. So if they're going to get rid of it, they would have to let us know. Okay, so next steps. Title VI and Section 1557 still remain the law. Again, those can't be changed. This Congress is not going to go in and change those. Even if the 1557 changes are finalized, they're not effective immediately, and there likely will be court challenges. Again, we would hope with similar results to what we saw with the public charge rule and the court decisions on Friday. Even if there aren't specific requirements for translation, for taglines, for notices, y'all can still do it. So you all can be thinking about how do you talk with the facilities you work with, whether you're on staff or whether you're contractors, that just because HHS doesn't require you to do it, it's still good practice. It's still important to notify people of their rights. You can still do all of this. And we'll see what happens. And just, again, 1557 goes beyond language access. And so there are currently cases that arguments were just heard last week also on what sex discrimination means and whether it covers LGBTQ individuals. That's may also implicate some of these provisions in the 1557 rules. So everyone take a deep breath. Yeah, exactly. This is my, okay, it's going to be okay. And everyone loves puppies and kittens. And so I just try to, again, end on a, not necessarily a high note, but take a deep breath. We're still where we are. We're still fighting back. We still have a lot of options. So what happens next? We expect that the 1557 rule will be finalized either later this year or next year. There were over 160,000 comments, so not quite as many as public charge, but quite a lot. There still will be these challenges to the public charge rule. We don't expect this administration to let up on its anti-immigrant policies. We don't know what's next, but stay tuned. But there are elections coming. And elections can make a difference. I'm not being partisan here. Elections just change things. And there may also be opportunities for health reform 2.0. So you probably heard a lot about Medicare for All and other proposals. Those give us opportunities, if they start to proceed, to improve language access. We made pretty good gains in the Affordable Care Act, addressing healthcare disparities. If things change in 2020 and we move forward with a different administration and we move forward with new opportunities for health reform, those of us who work at the national level are certainly going to be pushing to address language access and other disparities, and we need all of you to do the same. So what can you do? Monitor developments on all of this stuff, stay informed, help educate your clients and patients. If you don't know the answers, find out and get help. I'm happy for you to email me, but the Protecting Immigrant Families campaign is a great option as well, and get engaged. I'll just leave you with a couple resources. One of the things that we did recently at NHELP is we updated our 50-state survey of state law requirements addressing language access needs. So you all can go and look and see beyond Title VI and 1557, are there other laws in your state that give you leverage to improve language access? And then just some other resources from NHELP. We've got a lot of reports on our website. So thank you very much. Thank you to CCHI for inviting me. And thank you for letting me take the time to inform you about all of this important stuff while we're still celebrating our birthday.
Thank you so much for being here. It's such a pleasure to see you. And here's our small token of appreciation.
Thank you. Thank you very much. Oh yes. Oops. Oops. Pick something. Oh, stay there.
So we actually caught up with time. So if there are one or two questions from the participants, I'll come around with a microphone.
And I didn't even talk that fast.
This is Carlos Pava. In terms of your recommendation of monitoring developments, of course, there has been an army of people that for many years have been gathering information, collecting data to push towards this change in legislation that is meant to protect people's rights. And then in a matter of very short time, it seems like there was another army behind the scenes that was ready to take over and change everything. And now in terms of monitoring development, do we know what are these interest groups? How can we monitor more closely? Are there known interest groups that are behind these? I can imagine there's one person's bandera to just change everything. I'm sure there are many groups behind this.
Sure.
Can we have some more information about that?
It is hard because they keep their information pretty close to the vest. I mean, that's the reality. So there are certain organizations that we know are very anti-immigrant. And FAIR is one of them. I forget what FAIR, do you remember, Ig?
Federation for American Information Report and Numbers USA.
Yeah. And then there's Pro-English, which is the organization, at least, that's still pushing to rescind Executive Order 13166 and really focus on English-only policies as opposed to encouraging language access. So those are organizations to monitor. I think what I was saying in terms of monitoring developments is just keep up on this so that you know and you are aware, whether it's through Twitter, through Facebook, through websites, a Protecting Immigrant Families campaign, but this stuff does change. I mean, literally, I sent Natalia my PowerPoint earlier this week, and then the court decisions came out on Friday, and that's huge. We were waiting and expecting them because the rule is supposed to go into effect October 15th, but it is really important that you try to stay up on these developments, and so you can do that through the Protecting Immigrant Families campaign. NHELP is active on social media, and so we try to alert people when there's opportunities to provide public comment. You know, when the 1557 rule was up, we mentioned it on a couple CCHI webinars. CCHI put out information, National Council on Interpreting in Healthcare put out information, a number of the sponsors here put out information. So I think just try to find different opportunities to keep yourself informed so that you can, again, then educate yourselves and educate those who you're working with.
Thank you very much. Under the previous administration, there was a favorable administration there were many non-compliant entities of the country. Now things are even worse. The writings on the wall, many people are pulling out services. The whole department has been dismissed and canceled. What can we do in order to enforce compliance and monitoring, and then take a proactive action in order to bring these non-compliant entities to the open?
Sure. I think there's a couple of opportunities there. So one, under Section 1557, individuals can sue in court. They don't have to wait for the HHS to investigate complaints. Now, if you're interested in doing that, please contact us because we need to make sure the first court cases on language access, there's a lot of litigation concerns. We don't want to just see sort of a million flowers bloom and lots of people sue. You really have to make sure that if we're creating case law for the first time that we have the right cases and the right facts and that type of stuff. But that is a possibility. The second is to communicate with your elected representatives at the federal, at the state, and at the local level about what's needed. So check out what those state laws exist in your state. If you're in California, you're going to have over 100. A couple states only have 3. See what other states have done. Think about whether you want to get involved legislatively in your state or in your community about putting protections in place. Third, again, just educate the entities that you work with about their responsibilities. And sometimes it's the law works, and sometimes providing them the rationale that they will get more patients and therefore they will make more money helps. It can be carrot, it can be stick, it can be a mix of both, but I think there are different leverage points that individuals have. And the media can also be helpful. So if, an entity is not doing it, we've seen organizations do secret shopper surveys, and they call all the hospitals in their city and see what happens if they have someone speaking Spanish call or speaking Swahili call, and see what the response is. Do you actually get connected to someone who can speak your language? Do you get hung up on? And then you can use that to issue reports and to get media attention. So I think there are a variety of leverage points depending on where you are and what you want your involvement to be. And it can be as simple sometimes as taking, we have a document, frequently asked questions about Title VI, and giving it to an administrator or a clinic director because they just didn't know Title VI existed. And then they realize it and they move on, and they start working on it. So I think there's a variety of leverage points from the very legal to the policy to the media, and it really just depends where you are and how you want to engage. But hopefully working together and finding other people who are interested about these issues in your community, in your state, will also create more leverage to make improvements.
I'm Phil Rivers, and the Executive Director of the Joint National Committee for Languages. I lobby in Washington, D.C. on behalf of language access, all things language, and I work with Mara on and off for almost 20 years. There's a coalition out there fighting for language access. It includes the National Health Law Program, certainly protecting immigrant families, the Joint National Commission. I just want to underline, it's really important to sign up, follow on social media, and get involved. And there will be, if you follow us at Language, JNC on social media, there will be, when the next NPRM comes out, notice of proposed rulemaking, remember those stages that Mara put up there, we will ask people to submit comments. We aren't the only ones out there doing it, but CCHI is a member, a lot of the sponsors here are members. Talk to me, I'm here all day long, talk to Mara, but you need to get involved and stay informed. You have to know that there are people fighting on behalf of language access in Washington, D.C.
I should say, when those public comment opportunities arise, and they also exist in many states, your voice does matter. You don't have to have all the recent studies and statistics and data. You have stories about your daily experiences and the experiences from your clients and patients, and those sort of, qualitative studies, qualitative information is just as important to build that record as the quantitative ones. And you wonder why one voice matters? It does, because when we can get to 266,000 comments and 90% are opposed, that also helps us when we go to court. Because the judges take a look at that and they say, did the administration really consider all those comments? And if everyone was opposed, why'd they make those changes? So I really do want to nail home, your voice matters. And even if you write a paragraph of comments, do that, get it in, encourage your friends, your family, your clients, et cetera, to do that as well.
Let's take a last question here.
Okay. My name is Dan Huber. I'm not in
Another issue is funding. We talked about LEP patients, more revenue. That's not the case. Medicare, you lose money on patients. What I see as a gap is education and documentation on the importance of quality professionals so that we can tell the story to leaders in our hospitals and clinics of the fact that we're not providing efficient language access. And those patients are coming in the ED, and those patients have more impactful health situations that end up costing the organizations more money in the long run. So I'm just wondering what are we doing to really document some studies or get some factual evidence on the importance of having qualified professional language translators, professionals.
Well, this is an issue that has been a challenge as long as I've been working on language access, and I'm sure way before that. It is hard to show a return on investment or business case or the financial incentives. When I mentioned, in some places it does work. If you have more patients, you will get more revenue. If you're an integrated system like Fred described, and you're operating clinics as well as hospitals and emergency departments, you might be able to help show that getting people into the primary care and keeping them out of the emergency room will help save costs. But if you're in a hospital that is not connected to primary care, they're looking at their bottom line, and it doesn't matter to them necessarily, if someone is seen outside or inside, that you would hope, because it reduces wait times in the ER, et cetera. I think it's a challenge. And I think for a number of years, many of us were working on sort of the focus of patient-centered care. That it really shouldn't be about, does this cost money? But it should be about, how are we meeting our patients? And the Joint Commission did a lot of work on this and put out a patient-centered care roadmap and changed some of their standards. But it is a challenge. And I think there have been some studies that have showed having a competent or qualified interpreter makes a difference. There's less medical errors. But I think if we're only focusing on the business case, it is going to be a challenge. And I think instead it really is, how do we provide the patient-centered care that everyone needs? And it shouldn't be about the cost of doing it. It should be the right thing to do. We should be treating all of our patients the same. That's not a great answer. I recognize that, because a lot of entities are looking at that bottom line. And they say, I got to hire an interpreter, or I've got to, buy the new MRI machine or something like that. And it's a challenge. So I think it is something that we do need to encourage more research. But it is difficult if we're going to sort of still focus on how do we make this financially viable as opposed to how do we make this the right type of care that we provide for our patients. So thank you.
Let's thank Mara again.